Hi everyone and welcome to our module on joints of the upper limb. So as said in the previous section under the bones of the upper limb, we have a total of 32 bones in the upper limb and each of these bones tend to interconnect at different points we call joints. So joints typically refers to the junction between two or more bones, and in terms of the upper limb we have a total of about 10 joints in the upper limb. This includes the sternoclavicular joint and the acromioclavicular joints found in the pectoral region, the glenohumeral joint, also called the shoulder joint, the elbow joint, and the radioulnar joint found in the forearm, the wrist joints, and then a number of joints in the hand, like the intercarpal joint, the carpal metacarpal joint, the metacarpophalangeal joint, and the interphalangeal joint. Now, note that as we will talk about majority of the joints in this particular module, we'll not focus on everything, focus on the important ones. The important thing to note about every single one of these joints are um, concepts like the type of the joint. So every joint is classified based on the form of type. The articular surfaces of the joint, meaning what are the two bones and the surface of the bones involved in forming the joint. The component of the joint. Every joint has a component, has structures that tend to features that tend to make it distinct from others. We talk about the blood supply to a joint. So what are the arterial supply and venous drainage of the joint? We talk about nerve supply to the joint, and then most importantly, we talk about the movements that the joint tends to perform, and then the muscles involved in those movements. So the M and M, the movement and the muscles. One thing to note about the joints of the upper limb is that most of the joints of the upper limb are largely synovial. And this is very key to note. What exactly is a synovial joint? A synovial joint is one type of joint based on structure that has a combination of features that are unique to it. So features that we see in a joint that would make us to classify that joint as being synovial would be one, the joint would have a joint capsule. So it's a fibrous structure that tends to surround the joint and anchors all the articulating bones within the joint. The joint would have a synovial membrane. Synovial membrane is a slippery membrane that allows for movement within the joint. The synovial joint has a synovial cavity and synovial fluid within the cavity. And we usually see that the synovial joint is not necessarily formed when two bones are connected by an actual structures. The bones that are forming the synovial joint tend to have a space with it, and that space is referred to as the synovial cavity. Synovial joint will have ligaments that tend to anchor the articulating bones to each other and allow for stability. They also tend to have bossas. Bossas are usually extensions of the synovial joint into different aspects of the non-articulating aspect of the bones. This would reduce friction of muscles or ligaments on the bone surface. And then finally, the joints tend to have articular cartilages that lines the articulating surfaces. Show you a picture of how each of these features tend to look like in the next slide. So this is an image of a typical synovial joint. As we discussed, synovial joints would be a joint between two or more bones. As you can see, we have bone 1 above, this is the proximal bone, and we have bone 2 below, this is the distal bone, and they are articulating to form a synovial joint. How we know it's a synovial joint is because we can identify those features I mentioned that we see in a typical synovial joint. First will be the joint capsule. So this is a picture of the part of the joint capsule present here. It's the outermost part of the joint, and it tends to surround the entire articulating bones of the synovial joint. Second will be the synovial membrane. Synovial membrane is just a lining of membrane on the surface or the inner surface of the articular capsule. So this red portion here is the synovial membrane. That's the second structure or feature of the synovial joint. Then the synovial joint would have a space called the synovial cavity. In this case, they called it the joint cavity, but we cannot call it synovial cavity. And this cavity is filled with fluid, what we call synovial fluid. So one key thing I mentioned about the synovial joint is that unlike other types of joint, like the fibrous joint and the cartilaginous joint, a space exists between the articular surfaces. So between bone 1 and bone 2, there's a large space that is filled with fluid. And this is so to ensure that there is mobility within the joint. Synovial joint is one of the most mobile joints, and the reason why it is very mobile is because of that space between the two articulating bones. Then finally, we have some other structures like ligaments, like bossas, and then the articular cartilage. Articular cartilage is shown in this particular image. You can see the area line blue. This is the articular cartilage that tends to line the articulating surface. We are not finding ligaments or bossas in this image, but they are all important features of a typical synovial joint. Let's begin with the very first joint of the upper limb, the sternoclavicular joint. As the name implies, this is a joint that exists between the sternum of the axial skeleton and the clavicle of the upper limb, hence the name sternoclavicular. So it's the joint that tends to link the upper limb to the axial skeleton. It's the only joint linking the upper limb to the axial skeleton. The sternoclavicular joint is the joint that is responsible for our ability to thrust our shoulder and our arm forward. And for these functions to be performed, the joint needs to be sound and needs to be stable for that to occur. Now, the sternoclavicular joint is classified usually as a saddle joint based on the shape. Now, although it is classified as a saddle joint, the saddle tends to be the particular platform that horse riders tend to use in sitting on the horse. Although this sternoclavicular joint is classified as a saddle joint, it actually functions as a ball and socket joint, and that's just important to note. Aside this classification based on the shape, it can also be classified based on mobility as a multi-axial joint. So it's a joint in which we have multiple movements occurring at. And then finally, the sternoclavicular joint is an example of a synovial joint. I already talked about the features of a synovial joint. So when we talk about the components of the sternoclavicular joint, we'll make mention to some of those features we mentioned initially. One extra thing to note about the sternoclavicular joint is the fact that it's a joint that is divided further into two compartments. And what tends to divide it into two compartments is a structure within the joint space called the articular disc. So what are the articular surfaces of the sternoclavicular joints? As the name implies, the sternoclavicular joint will be formed from two bones, the clavicle and the sternum. But to be very specific about the articular surfaces, for the clavicle, the articular surface involved in forming the sternoclavicular joint is the sternal end of the clavicle, and then from the sternum, it's the clavicular notch of the mandible. In addition to this, we have a portion of the first costal cartilage being involved in forming the joint. So we have three major components of articular surfaces that gives rise to the sternoclavicular joint. Each of these surfaces that will join together to form the sternoclavicular joint are lined by a special articular cartilage. In this case, it's the fibrocartilage that tends to line it. So that the various components of the sternoclavicular joint. Remember that the sternoclavicular joint is an example of a synovial joint. So it's going to be a joint that on the outside would have a joint capsule, which is made up of the fibrous capsule and the synovial membrane. Fibrous capsule tends to surround the entire joint and attaches to the edges of the articular surfaces. So it attaches to the epiphysis of the sternal end of the clavicle and the edges of the clavicular notch of the mandibulosternum. Synovial membrane, on the other hand, tends to line the inner surface of the fibrous capsule. Aside the joint capsule, one unique feature about the sternoclavicular joint is the presence of an articular disc. This disc is present to, first of all, divide the sternoclavicular joint into two compartments, but secondly, the articular disc tends to serve as the shock absorber for forces transmitted from the clavicle towards the upper limb. As a synovial joint, the sternoclavicular joint would also be maintained by ligaments. And there are three major ligaments that are found on the sternoclavicular joint. This includes the sternoclavicular ligaments, the interclavicular ligaments, and the costoclavicular ligaments. And each of these ligaments tend to perform different functions. The sternoclavicular ligament, for example, helps in reinforcing the anterior and posterior part of the joint. So they strengthen the anterior and posterior part of the sternoclavicular joint. The interclavicular ligaments tend to strengthen the joint superiorly, and then finally, the costoclavicular ligaments tends to limit elevation of the entire pectoral girdle at that joint. The blood supply to the sternoclavicular joint comes from two major arteries, and these arteries include the internal thoracic artery and the suprascapular artery. And then the venous counterpart would also follow the names. We have the internal thoracic veins and the suprascapular veins also draining venous blood from the joint. With regards to the nerve supply to the sternoclavicular joint, firstly, it's important to note that when talking about nerve supply to any joint, there's a typical law that tends to guard and explain the nerve supply to all joints. And this law is known as the Hilton's law. So Hilton's law states that joints are supplied by articular branches of nerves supplying the muscles that act on the joint. So if you're lost, for example, and you're thinking about the nerve supply to a particular joint, first thing you need to do is just think about the muscles that tend to act on those joints. So the muscles acting on the joints, the nerve supply to those muscles will be the nerve supply to the joint itself. So in the case of the sternoclavicular joint, the two major nerve supply includes the medial supraclavicular nerve and the nerve to the subclavius muscle. And this is an image of the sternoclavicular joint that we just talked about. You notice that the joint between the clavicle on the lateral side here and then the manubrium of the sternum on the medial side. And this is the joint present here. You can see there are some structures present or components present with injury. You can see a ligament there. You can see the anterior sternoclavicular ligament. We can see the interclavicular ligament above. It's a ligament that spans the sternal end of both clavicles. So sternal end of the clavicle on the right side, sternal end of the clavicle of the left side, and that's the interclavicular ligament. We can't see the other ligaments there, but we could also see some of the ligament you mentioned, like the costoclavicular ligament. You can't see the posterior sternoclavicular ligament, unfortunately. Now, note that the sternoclavicular ligament joint is a joint that allows a very mobile joint, a joint that allows significant movement of the pectoral girdle and the upper limb. Although we don't really pay too much attention to the type of movements that occur there and the muscles involved in it, but just to note, it's a very mobile joint and it allows for significant movement of both the pectoral girdle and the upper limb. The acromioclavicular joint is a joint existing between the scapula and the clavicle. As the name implies, it's the joint between the acromion of the scapula and the clavicle. And this joint is a joint that permits a greater range of upper limb motion, and it tends to act as the strut that maintains the upper limb away from the thorax. The acromioclavicular joint is classified based on shape as a plane joint. In terms of mobility, it's classified as a multi-axial joint. So movements around that joint tend to be at different directions. And then finally, based on structure, it is classified as a synovial joint. So it's going to be having some of the components of features of the synovial joint that we mentioned in the previous slides. In terms of its location, it is located 2 to 3 centimeters from the point of the shoulder, formed by the lateral part of the acromion. What are the articular surfaces of the acromioclavicular joint? Being very specific, the two articular surfaces of the acromioclavicular joint include first the acromion process of the scapula, and that is found in the name. Then secondly, the acromial end of the clavicle. And each of these articular surfaces are going to be lined by articular cartilage. The particular articular cartilage that lines the acromioclavicular joint is a fibrocartilage. So we see fibrocartilages both as the articular cartilage that lines the acromioclavicular joint and the sternoclavicular joint. And also, one very similar thing in terms of those two joints is the fact that there's articular discs that tend to separate them into two compartments. So we have an articular disc separating the sternoclavicular joint into two compartments. We also have the acromioclavicular joint being separated into two compartments by its own articular disc. What are the components of the acromioclavicular joint? Remember that this is also a synovial joint, so it's going to be having some of the features we mentioned that we see in a typical synovial joint. Starting with the joint capsule. The joint capsule is made up of two parts, the fibrous capsule and the synovial membrane. The joint capsule of the acromioclavicular joint tends to be sleeve-like. It's very loose in terms of its texture, and because it's very loose in terms of its texture, it tends to be strengthened superiorly by a muscle. Usually, the trapezius muscle strengthens it superiorly. And we have the synovial membrane that tends to line the inner surface of the fibrous capsule. And then we have the articular disc, which is a wedge-shaped structure that separates the articular space of the acromioclavicular joint into two surfaces. Just like other synovial joints, the acromioclavicular joint would also have its own set of ligaments that strengthens it. The two major ligaments found in the acromioclavicular joint would include the acromioclavicular ligament and the coracoclavicular ligament. The acromioclavicular ligament is a ligament that connects the acromion to the clavicle, and it tends to strengthen the joint superiorly. So it's important to note where these ligaments are reinforcing in terms of the location of the joint. The coracoclavicular ligament, on the other hand, is a ligament that is two in one. It's connecting the coracoid process of the scapula to the clavicle, quite alright, but it's further divided into two parts. We have a conoid portion and a trapezoid portion. So there's a conoid ligament and a trapezoid ligament. The combination of those two ligaments would give rise to the coracoclavicular ligament. This is a ligament that tends to augment the entire acromioclavicular joint. It provides the means by which the scapula and the free limb are suspended from the clavicular strut. The blood supply to the acromioclavicular ligament are two major vessels, the suprascapular vessels, which are arteries and veins, and then the thoracoacromial vessels, also arteries and veins, tend to either supply arterial blood or drain venous blood from the acromioclavicular joint. And finally, the nerve supply to the acromioclavicular joint is done by three major nerves. It includes lateral pectoral nerve, the axillary nerve, and then the lateral supraclavicular nerve. Some of these nerves are sensory in their function. Some of them are motor and sensory and mixed in their function. This is an image of the acromioclavicular joint. As you can see, the joint, it's a very, very small joint found laterally at the shoulder region. It's a joint that tends to have very little movement occurring there, though the movement that we see around that region is not done at the joint. It's done by a physiological joint we call the scapulothoracic joint. So note that there are really no movements present at the joint. The reason why we don't really have movements at the joint is because we don't really have muscles acting on those joints as well. So the movement that we see around that joint is due to a physiological joint we call the scapulothoracic joint. Moving on to the shoulder joint. The shoulder joint, also called the glenohumeral joint, is the largest joint in the upper limb. This joint is the joint that exists between the scapula and the humerus. The shoulder joint or the glenohumeral joint is the joint that is classified based on shape as a ball and socket joint. We'll talk about why it is called a ball and socket joint when we get to the articular surfaces. Aside the classification based on shape, it is classified also based on mobility as a multi-axial joint. In fact, it's one of the most mobile joints in the body. In fact, it is very mobile to the point in which it becomes unstable as a result of its mobility. So we say that shoulder joint is a joint that tends to peak mobility over stability. It's a very unstable joint, but that instability has been replaced with mobility. And then finally, the shoulder joint is an example of a synovial joint, so it would contain most of the features we mentioned regarding the synovial joint. What are the articular surfaces of the shoulder joint? There are two major articular surfaces, one from the scapula, the other in the humerus. Part of the scapula that tends to form the shoulder joint is the glenoid cavity. Hence the reason why we call it the glenohumeral joint, because the glenoid part is mirroring what we see in terms of the glenoid cavity. Then finally, the head of the humerus is the part of the humerus that gives rise to the shoulder joint. And the reason why we call the shoulder joint the ball and socket joint is because the head of the humerus tends to be rounded in shape, so that forms like the ball portion of the ball and socket. And then the glenoid cavity tends to be shallow and pear-shaped in form, and it looks like a socket or a bowl. So we refer to it as ball and socket because the ball there stands for the head of humerus, and then the socket stands for the glenoid cavity. Please note that these two articular surfaces, the ball and the socket portion of the shoulder joint, do not fit in perfectly. In fact, we usually say that the glenoid cavity cannot really fit up to two-thirds of the head of humerus. The head of humerus is larger compared to the glenoid cavity, and as a result, we need the glenoid cavity to be deepened, and we need structures to hold the head of humerus in place. We'll talk about those structures when we get to the components of the shoulder joint. One more thing to note is that the articular surfaces of the shoulder joint are lined by articular cartilage. In this case, this cartilage is the hyaline cartilage rather than fibrocartilage. Remember that for the sternoclavicular joint and the acromioclavicular joint, the articular cartilage that lines the joint are fibrocartilages. In the case of the shoulder joint and every other joint in the upper limb, it tends to be hyaline cartilage that lines the articular surfaces. This is an image of the shoulder joint. You can see the articular surfaces, each the head of humerus having this rounded for appearance. So it forms the ball that we talk about in terms of ball and socket, and then the glenoid fossa has this cup shape or depressed pear-shaped cavity, and that in that sense we tend to call it the socket in the ball and socket. And both of them are lined by hyaline cartilage. And as I said before, the glenoid cavity tends to be deepened further by structures like the glenoid labrum and the rotator cuff muscles. We'll talk about that when we get to the component, because the glenoid cavity is not so deep; it's very shallow, and as a result, it doesn't allow the head of humerus to fit into it perfectly. The shoulder joint is a synovial joint, so as a result, it's going to contain most of the features of a synovial joint. So first will be the joint capsule. The joint capsule of the synovial joint contains fibrous part and then the synovial membrane. The fibrous part would surround the entire joint and attach to the margins of the articular surfaces. In terms of the synovial membrane, it lines the inner portion of the fibrous capsule. Please note that the joint capsule tends to be thin and lax and allows a wide range of movement. So as a result, this is one of the things that tend to allow for instability of the joint because of how thin and lax the joint capsule is. Just like every other synovial joint, the shoulder joint would also have its own set of ligaments that strengthens it. There are four major ligaments of the shoulder joint. They include the glenohumeral ligament, the coracohumeral ligament, the coracoacromial ligament, and the transverse humeral ligament. The glenohumeral ligament, for example, is a ligament formed by three bands of fibrous tissue, and they tend to strengthen the front of the capsule of the shoulder joint. The coracohumeral ligament is a ligament that would extend from the coracoid process of the scapula and run down to the humerus. This is a ligament that tends to strengthen the capsule from above. It strengthens the superior part of the joint and tends to be very important in preventing dislocation of that joint. The coracoacromial ligament is a ligament that extends from the coracoid process to the acromion and is involved in protecting also the superior part of the joint. So both the coracohumeral ligament and the coracoacromial ligament tends to protect the joint superiorly. And finally, we have the transverse humeral ligament. This is a ligament that runs between the bridge of the intertubercular sulcus, and it's a ligament that tends to just help in keeping in check the long head of the biceps muscle as it runs through the intertubercular sulcus. So these are pictures of each of the ligaments of the shoulder joints, starting with the coracoacromial ligament in yellow. You can see the ligament extending from the coracoid process of the scapula all the way to the acromion of the scapula. And it tends to help in protecting the superior part of the joint. Then we have the coracohumeral ligament extending from the coracoid process of the scapula towards the humerus, and this also tends to protect the superior part of the joint. We have the glenohumeral ligament here in blue. We can see it surrounding almost the entire aspect of the joint. This protects the joint anteriorly. Then we're not really seeing this visibly, but there's supposed to be a joint that would span the intertubercular sulcus. As I'm drawing a line, this would indicate where the joint is meant to find. This is the transverse humeral ligament. It runs from the greater tuberosity to the lesser tuberosity, and it tends to keep the long head of the biceps. This is the long head of the biceps in white. So long head of the biceps is kept in place by the transverse humeral ligament. Right, so this image shows a ligament once more, but in this case we can see the transverse humeral ligament. This is the transverse humeral ligament shown here. You can see how it keeps the long head of the biceps in check. Alongside that, we can also see the other ligaments like the coracohumeral ligament, the coracoacromial ligament, and then the glenohumeral ligament. This is the ligament that tends to have three bands of fibrous tissue. You can see the three bands superiorly, middle, and then inferiorly, and they strengthen the anterior part of the joint. Other important components of the shoulder joint that are unique to the joint include the glenoid labrum and the rotator cuff muscles. I remember I said that the glenoid cavity is a shallow cavity, it's not so deep, so it doesn't allow the head of the humerus to fit into it perfectly. So one way in which the body deepens the glenoid cavity and allows the head of the humerus to fit in directly is through these two other components, the rotator cuff muscles and the glenoid labrum. First, the glenoid labrum tends to be a fibrous tissue that deepens um, the glenoid cavity. It's found at the edges of the glenoid cavity, so it deepens it and allows the head to fit into it well. Whereas the rotator cuff muscles are muscles that tend to surround the entire joint and they tend to hold the head of the humerus in place. So the major rotator cuff muscles we refer to them as the seat muscles. They include the suprascapularis muscle, the supraspinatus muscle, infraspinatus muscle, and the teres minor muscle. This is a picture showing us the rotator cuff muscles. You can see each of the muscles there color coded. In green, we have the subscapularis muscle. In red, we have supraspinatus muscle. In blue, we have the infraspinatus muscle, and then in yellow, we have the teres minor muscle. Just remember the acronym SIT: S for supraspinatus, I for infraspinatus, T for teres minor, and S, the last S there for subscapularis. Please do remember it is teres minor and not teres major. This is one way they will test you on. They can either switch teres minor to teres major just to confuse you. The shoulder joint also has its own fair share of bursas. Bursas are usually extensions of the synovial joint out of the synovial space into the non-articulating aspect of the bones or that forms the shoulder joint. We have four major bursas of the shoulder joint. This includes the subdeltoid bursa just directly beneath the deltoid muscle, subacromial bursa directly beneath the acromion, subtenuous bursa of subscapularis beneath the subscapularis muscle, and then the synovial sheath that surrounds the long head of the biceps. These are all bursas that are extending out of the synovial cavity and they tend to surround they're found beneath muscle structures and tendons. Right, these are pictures of bursas that we talked about. You can see the subscapular bursa just beneath the subscapularis muscle in green. You can see coracoid bursa. I already mentioned about this. It's just an extension of the subscapular bursa. And then we can see subacromial bursa. This in this image, we're not really seeing the subdeltoid bursa or the synovial sheath that surrounds the lung of the biceps. The shoulder joint is supplied by a bunch of vessels, usually the anterior circumflex humeral artery and posterior circumflex humeral artery, alongside the suprascapular artery involved in supplying the shoulder joint. These arteries also have the onset of veins that will be involved in draining venous blood. Remember that the anterior and posterior circumflex humeral arteries are branches of this third part of the axillary artery, and these arteries are going to be found around the surgical neck of the humerus, and as a result, they have easy access to the shoulder joint. The nerve supplied to the shoulder joint follows the Hilton's law. Remember that Hilton's law states that joints are supplied by articular branches of nerves that supply muscles acting on those joints. So in the case of the shoulder joint, the muscles acting on them, the nerves supplying those muscles will also supply the joint itself. So nerves like the axillary nerve, the suprascapular nerve, and the lateral pectoral nerve are nerves supplying the shoulder joint. Let's talk about the movement present within the shoulder joint, and then we'll talk about the muscles that are involved in performing those movements. So we have a total of about 4 pairs of movements that we see in the shoulder joints. This includes flexion and extension, abduction, adduction, internal rotation, external rotation, and then circumduction. Let's start with flexion and extension. So flexion and extension is a movement at the shoulder joint that involves either movement of the upper limb, usually front, forward, or backward. So flexion is raising up the arm in the lateral plane from 0 to about 180 degrees, as you can see. Flexion is moving anterior movement of the upper limb from 0 to about 180 degrees, as you can see in this image. Extension is moving it back to an anatomical position. So if you're flexed to 180 degrees, moving it back towards the anatomic position just by the side of the trunk is extension. But it's also a movement we call hyperextension, in which we can move the arm further back. Like imagine you're swinging your arm backwards, but we can only do this type of movement to about 45 degrees backwards. So flexion could be done from 0 to 180 degrees and forward. Extension is putting the hand back to the natural position, and then hyperextension is moving it backwards, and the limit usually is about 45 degrees in the lateral plane. Then we have abduction and adduction. Abduction is the movement of the arm away from the frontal plane, away from the middle of the body. So moving is usually either in 0 to 180 degrees. And there are different muscles involved in abduction. We'll talk about that when we talk about the muscles involved in each of the movements. There is a muscle that is involved in moving the arm from 0 to 15 degrees. There's one involved in moving it from 15 degrees to 90 degrees, and there's one involved in moving it from 90 degrees to 180 degrees. In terms of adduction is movement of the arm towards the midline, towards the body, and it's moving it from 180 back to 0 degree. So in terms of adduction, you're moving the arm away from the frontal plane, away from the midline. In terms of adduction, ADD, we're moving it towards the frontal plane or towards the midline, as you can see. Then the third pair of movement we have is internal rotation and external rotation. Internal rotation is a movement that occurs at the transverse plane, and it's a movement 90 degrees towards the body. As you can see, internal rotation, you are rotating the arm towards the body, but in a 90 degrees movement. So usually we use the forearm and the hand as our benchmark for the 90 degrees. You can see how this relationship between the arm and the forearm is perpendicular to each other, but the movement of the forearm is going to be towards the body. That's what we call internal rotation. Once the forearm is moving, it's pointed towards the body. It's called internal rotation at a 90 degrees angle to the arm. External rotation is also a movement occurring at transverse plane. It's also a movement 90 degrees, but is away from the midline. So in this case, you can see that the arm and the forearm are perpendicular to each other, and we can have a rotation at that portion of the arm that leads to the movement of the forearm away from the midline, as you can see, and that's what they call external rotation. We can also call external rotation lateral rotation, and we can also call internal rotation medial rotation. So in case you see that, just know that they are one and the same. Let's talk about the muscles involved in each of the movements we just mentioned, starting with the flexion and extension movements. For flexion usually is done by a combination of different muscles. The most The strongest muscle involved in flexion is the deltoid muscle, particularly the anterior fibers of the deltoid muscle. Alongside the deltoid muscle, we also have the pectoralis major muscle, the biceps brachii muscle, and the coracobrachialis muscle, all involved in the movement of flexion of the arm at the shoulder joint. For extension, extension is a movement that we perform with other muscles. Remember that extension tends to be towards the natural position, but we can hyperextend towards 40 degrees angle backwards. The major muscles involved in extension includes the deltoid, or in this case, the posterior fibers of the deltoid. So the anterior fibers of the deltoid is involved in flexion. The posterior fibers of the deltoid is involved in extension. Alongside the deltoid, we have the teres major muscle and the latissimus dorsi muscle involved also in extension. Then we have the abduction, ABD. Abduction is a movement, like I said, that involves the movement of the upper limb away from the midline. The muscles involved in abduction includes the deltoid muscle. In this case, it's the middle fibers of the deltoid. So anterior fibers of the deltoid is involved in flexion. The posterior fibers of the deltoid is involved in extension. But the middle fibers of the deltoid is involved in abduction. Then we have the supraspinatus muscle, the trapezius muscle, and the serratus anterior. Remember, I mentioned the fact that abduction tends to occur from 0 to 180 degrees. Now note that supraspinatus muscle is involved in initiating abduction. So it's the muscle that will be involved in performing 0 to 15 degrees abduction. The deltoid muscle is involved in taking this abduction further to 90 degrees. So it runs from 15 degrees to 90 degrees. That's what deltoid tends to do. And then the trapezius muscle and the serratus anterior muscle are both involved in moving the arm from 90 degrees angle to a 180 degrees angle in abduction. Then for abduction, ADD, movement of the arm back towards the natural position, close to the midline. We have um, four major muscles involved in this. We have the pectoralis major muscle, the teres major muscle, the latissimus dorsi muscle, and the teres minor muscle, all involved in the process of adduction, ADD. Let's move on to the last two and three or three movements found in the shoulder joint: internal rotation and external rotation, and then circumduction. Internal rotation is done by a bunch of muscles, similar muscles that we see in adduction. So muscles like pectoralis major, pectoralis major, teres major, latissimus dorsi, and then the subscapularis muscle are all involved in internal rotation. Usually, internal rotation tends to occur at an angle of 55 degrees towards the midline. It's a rotatory motion, not necessarily just a straightforward movement. It's a movement that occurs on a transverse plane. And then the external rotation or lateral rotation is done usually by teres minor muscle, infraspinatus muscle, and the deltoid muscle. A bit of the deltoid muscle is involved in lateral rotation. Lateral rotation is usually done in an angle of 40 to 45 degrees and is usually a rotatory movement done around the transverse axis. Circumduction is the last movement I'm here to talk about. It's a movement that involves the combination of most of the other movements we mentioned. So it's a movement in which the distal end of the humerus moves in a circular motion while the proximal end remains stable. And usually it tends to involve flexion, abduction, extension, and adduction in that successive manner. So we start with flexion first, we flex, then we adduct, then we extend, then we adduct to perform circumduction. Talking about the elbow joint is a compound joint. The reason why we call it a compound joint is that unlike most of the other joints we talked about, the elbow joint usually is a joint that exists between three major bones. So the bones include the humerus, the ulna, and then the radius. Most of the joints that we mentioned are joints existing between two bones. The exception being the elbow joint, which is a compound joint existing between three bones. In terms of type, the elbow joint is classified based on shape as a hinge joint, so it looks like the hinge of a door. In terms of movement, it's a uniaxial joint, so it's a joint that only allows movement in one plane. And then finally, based on structure, is classified as a synovial joint. And in terms of position, the elbow joint is a joint located 2 to 3 centimeters below the epicondyles of the humerus. We have four major articular surfaces of the elbow joint. Alright, some would come from the humerus and some from the radius and ulna. For the humerus, the two major articular surfaces found in the humerus would be the trochlea of the humerus and the capitulum. For the radius, it's the head of the radius that would articulate to form the elbow joint. And then for the ulna, it's the trochlear notch of the ulna that articulates to form the elbow joint. One thing to note about these articular surfaces in terms of their shape is that the trochlea of the humerus tend to be spool shaped, whereas the capitulum tends to be spheroidal in shape, and this is one area they can test you. And each of these articular surfaces are lined by hyaline cartilage. This is contrast to what we see in the acromioclavicular joint and the sternoclavicular joint, but it is similar to what we see for the shoulder joint. So the four articular surfaces of the elbow joint is depicted in the image shown on the screen. So the articular surfaces again includes the trochlea capitulum of the humerus. This is the trochlea of the humerus. You can see how it looks like a spool shaped. And then we have the capitulum on the lateral side that looks like a spheroid or a spiralar in shape. The capitulum tends to articulate with the head of the humerus, or head of the radius rather, whereas the trochlea would articulate with the trochlear notch of the ulna. The elbow joint is also a synovial joint, so it will contain features that we see in a typical synovial joint. This includes the fibrous capsule alongside its synovial membrane that gives rise to the joint capsule. The joint capsule of the elbow joint is one that tends to surround the entire joint. It attaches to the margin of the articular surfaces of the joint. So it's going to be attaching to the margin of the trochlea and capitulum of the humerus, and then the head of radius and the trochlear notch of the ulna. The synovial membrane would line the internal surface of the joint itself, and it tends to restrict friction. One very important thing to note about the joint capsule of the elbow joint is the fact that this joint capsule blends in with, or is continuous with, another joint found within the forearm called the proximal radioulnar joint. I'll show you a picture of how that tends to occur. So this is a picture of the joint capsule of the elbow joint. You can see it in yellow. And what you notice about this particular joint capsule is that it extends below this structure called the annular ligament, and it tends to be continuous with this portion of the um, forearm. This part of the forearm is actually a second joint called the proximal radioulnar joint. So the joint capsule in the proximal radioulnar joint is going to be mixing up with the, or is going to be continuous with the joint capsule of the elbow joint, as you can see in this image. Just like every other synovial joint, the elbow joint would have its own fascia of ligaments that strengthens it, and it also has bursas that tend to serve as extensions to the synovial membrane. In terms of the ligaments, we have two major ligaments found in the elbow joint. This includes the radial collateral ligament and the ulnar collateral ligament. Sometimes we can call the radial collateral ligament, we can call it lateral collateral ligament. That's because it tends to strengthen the lateral part of the joint. And then we can also call the ulnar collateral ligament, you can call it the medial collateral ligament, because this is because it tends to strengthen the medial part of the joint. One extra thing to note about the ulnar collateral ligament, it's a ligament that is formed by three bands. It's usually an anterior band, a posterior band, and then a slender oblique band. The anterior band of the ulnar collateral ligament is the strongest, the posterior band is usually the weakest, and then the oblique band tends to be found running or deepening the socket of the trochlea of the humerus. Alright, that's just by the way. The other components to note about the elbow joint are the bursas. So we have two major bursas of the elbow joint. We have the biceps bursa, also called the bicipitoradial bursa, and we have the olecranon bursa. The olecranon bursa is further divided into three subparts. We have the intratendinous olecranon bursa, alright, that's within the tendon of the triceps muscle. We have the subtendinous olecranon bursa just beneath the tendon of the triceps muscle, and then we have the subcutaneous olecranon bursa that is just directly beneath the skin of the elbow. This is the image showing us some of the joint capsule alongside the ligament of the elbow joint. As you see, we have the joint capsule in green surrounding the entire joint. Remember, the joint capsule tends to extend into the joint capsule of a separate joint we'll talk about next, which is the proximal radioulnar joint. Aside the joint capsule, we also have the ligament that tend to strengthen the joints medially and laterally. We have the ulnar collateral ligament in red, strengthening the joint medially, as you can see. And then laterally, we have the radial collateral ligament that strengthens it laterally. There's one more joint shown in this image called the annular ligament, but this particular ligament is not a ligament that we talk about for the elbow joint. The ligament we talk about in the proximal radioulnar joint in the next slide. This is an image showing us the ligament once more. We can see the radial collateral ligament in this image alongside the fibrous joint capsule and the annular ligament shown in this picture. In this area, we can see the medial side, the medial collateral ligament or the ulnar collateral ligament, and you can see how it has those three bands that we talked about, the anterior, posterior, and the oblique band that tends to form it. The elbow joint is supplied by a bunch of vessels, so we have a lot of arteries and veins that tend to supply it. Usually, these vessels are branches of the brachial vessel itself and radial and ulnar vessel. So, the brachial vessels, brachial artery, and veins give branches that would anastomose with the branches of the radial ulnar and ulnar vessels, the recurrent branches of the radial ulnar vessels. So as a result, this anastomosis is what gives blood supply or venous drainage to the elbow joint. The nerve supply to the elbow joint follows Hilton's law. Remember that Hilton's law states that joints are supplied by articular branches of nerves, supplying the muscles that act on those joints. So in the case of the elbow joint, muscles acting on those joints, the nerve supplied to those muscles will be supplying the joint itself. So in the case of the elbow joint, we have the musculocutaneous nerve, the radial nerve, and the ulnar nerve supplying the joint because we have muscles that are found around those joints being innervated by these nerves. Let's talk about the movement and the muscles of at the elbow joint. Remember that the elbow joint is uniaxial, meaning it has just one form or pair of movement at a single plane. In the case of the elbow joint, being a hinge joint, the only set of movements we find here is flexion and extension movement. That's a pair of movement. Flexion or at the elbow joint is done by three major muscles. These are the primary muscles of the flexion. This includes the biceps muscle, the brachialis muscle, and the brachioradialis muscle. You can see each of these muscles tend to end with start with a B. Please note that the biceps and the brachialis muscle are the major flexors of the forearm at the elbow joint. The brachioradialis muscle and the prenatal teres usually tend to assist in flexion. So I didn't add the prenatal teres, but it's also a muscle involved in assisting. Please note, brachioradialis tend to produce rapid flexion in the absence of resistance, whereas in the presence of resistance, it works together with prenatal teres to assist flexion. So brachioradialis is purely an assistant in terms of flexion, whereas the biceps and brachialis are the pure flexors or strong flexors or primary flexors of the elbow joint. For extension, the major muscle involved in the extension of the elbow joint is the triceps brachii muscle. The muscle that tends to assist it in extension is the anconeus muscle. So this is an image showing us flexion and extension at the elbow joint and at the wrist joint. Our focus should be on the elbow joint. So at the elbow joint, you can see there's a flexion occurring at the elbow joint where we have movement of the forearm towards the arm. So once you have movement of the forearm towards the arm, you're flexing, and then extension is movement of the forearm away from the arm. That is extension. So flexion, like I said, is done by the B muscles, the biceps muscle, brachialis, and brachioradialis. Brachioradialis alongside prenatal teres helps in assisting. Extension is done by the triceps muscle alongside anconeus, which also helps in assisting. So this is an image of a woman flexing her forearm at the elbow joints. You can see the movement of the forearm towards the arm in this case. So usually how we can strengthen some of our biceps muscle, because the biceps is usually involved in flexion. If you are working out by doing exercises that involves continuous flexion, so using dumbbells flex would improve the activity of your biceps muscle and lead to hypertrophy of the muscles. That's how we tend to build muscle when we are working out. Let's talk about the radioulnar joint. The radioulnar joint is the joint that we see within the forearm. It's a joint between the radius and the ulnar, and it's a joint involved in a very unique type of movement we see around that particular region. We have two types of radioulnar joints. There's a proximal radioulnar joint, I found proximally very close to the humerus, and there's a distal radioulnar joint found distally very close to the arm. So the proximal radioulnar joint is in close proximity to the elbow joint. The distal radioulnar joint is in close proximity to the wrist joint. The radioulnar joints are classified based on shape as a pivot joint. Based on movement, they are classified as a uniaxial joint. We have just one pair of movements we see at the radioulnar joint. And then based on structure, they are classified as synovial joints. So we tend to see features of a typical synovial joint in the radioulnar joint. So what are the articular surfaces of the radioulnar joints? Starting with the proximal radioulnar joint. This is formed when the head of the radius articulates with the radial notch of the ulna. In the case of the distal radioulnar joint, it is formed when the head of the ulna articulates with the ulnar notch of the radius. Each of these articular surfaces will be lined by articular cartilages, particularly the hyaline cartilage. The radioulnar joints are both synovial joints, so they will be covered by a joint capsule that contains both fibrous capsule and synovial membrane. The joint capsule of the proximal radioulnar joint, like I said before, is continuous with the joint capsule of the elbow joint, whereas the joint capsule of the distal radioulnar joint is separated from the wrist joint by an articular disc. This is very important to note. So we although we have continuation in the joint capsule of the proximal radioulnar joint with the elbow joint, we don't have that same continuation at the wrist joint in terms of the distal radioulnar joint. For the synovial membrane of the proximal radioulnar joint has an inferior prolongation, tends to prolong inferiorly towards the elbow joint. And the synovial membrane of the distal radioulnar joint usually extends between the radius and the ulna, and then it forms a recess called the saciform recess of the distal radioulnar joint. Just like every other synovial joint, the radioulnar joint would also have its own fair share of ligaments that strengthens it. The proximal radioulnar joint has a single ligament called the annular ligament. In the previous slide, I showed a picture of how it looks like. The annular ligament tends to attach to the ulna anteriorly and posteriorly and at the radial notch, and then it tends to encircle the entire radius, the entire neck of the radius, and that's what we tend to refer to as an annular ligament. It has a ring shape. One other thing to note about the annular ligament is that the annular ligament, the synovial membrane within the proximal radioulnar joint tend to extend into the annular ligament, forming its own form of saxiform recess. Remember, there's a saxiform recess that we see in the distal radioulnar joint. There's also a saxiform recess we see at the proximal radioulnar joint. This recess tend to occur as a result of extension of the synovial membrane into the annular ligament. In terms of the distal radioulnar joint, we have two major ligaments, anterior and posterior ligaments of the radioulnar joint, and they tend to strengthen the joint anteriorly and posteriorly, as the name implies. This is a picture of the annular ligament in green. You can see how it starts from the radial notch of the ulna and then encircles the entire neck of the radius, hence the reason why we call it annular ligament. For the blood supply to the radioulnar joint, the proximal radioulnar joint is supplied by the radial part of periarticular anastomosis of vessels around the elbow joint. So arterial supplies to the elbow joint, part of it is going to be extending to the radioulnar joint proximally. For the distal radioulnar joint, the vessels that tend to supply will include the anterior interosseous vessels and the posterior interosseous vessels. The nerve supply to the radioulnar joint follows Hilton's law. Remember that Hilton's law states that the joints are supplied by articular branches of nerves supplying the muscles that act on those joints. So in the case of the proximal radioulnar joint, the nerves that supply the joint include musculocutaneous nerve, the median nerve, and the radial nerve. For the distal radioulnar joint, we have the anterior interosseous nerve and posterior interosseous nerve supplying the distal radioulnar joint. The radioulnar joint has a very unique set of movements. The movements we see at the radioulnar joint are called supination and pronation movements. These are rotatory movements of the forearm and the hand around a vertical axis. Now, note that amongst the two, supination tends to be the most powerful amongst them, so it's more powerful than pronation. And usually, the movements tend to permit a form of rotation of the radius on the ulna, in which when we supinate, the palms of the hand will face upward or face anteriorly, depending on how we are standing. And when we pronate, the palms of the hand will face downwards or posteriorly, depending on how we are standing. So pronation involves palms down, supination involves palm up. What are the muscles involved in pronation and supination? For pronation, we have a bunch of primary muscles and accessory muscles involved in the movement. For pronation, we have pronator teres and pronator quadratus involved in movement. Amongst these two, pronator quadratus is the most important pronator of the forearm. And then for supination, we have the supinator muscle, which is the main muscle, and the biceps brachii muscle, which is an assistant muscle. Biceps brachii is also regarded as a very powerful supinator in a scenario where the person's forearm is pronated already. So this is the image showing us the act of pronation and supination. And what you notice is that in pronation, what you have is you have the rotation of the radius on the ulna. In supination, on the other hand, we have that particular movement being reversed. So we have the radius unwinding itself from the ulna and then just being parallel to the ulna automatically. Just one more. Remember that we can have supination being described as palm up or palm anterior, and then pronation being palms down or palms posterior. Please do note that it depends on how the person is being positioned. In anatomical position, When the person is having a supinated forearm, the palms will be facing anteriorly. If the person is having a pronated forearm, the palms will be facing posteriorly. In a supine position, the other way around, the palms will be facing upwards in supination and downwards in pronation. The final joint we'll be talking about on this model is the wrist joint. The wrist joint is also called the radiocarpal joint. The joint between the radius and some of the proximal carpal bones. It's not a joint that is formed between the radius and the ulna and the carpal bones. The ulna does not take part in the formation of the wrist joint. In fact, the portion of the ulna, the part of that is related to the ulna that forms the wrist joint is an articular disc, and that would serve as the continuation or replacement of the ulna in this particular joint. The wrist joint is referred to as a condylar or ellipsoid joint in shape, right? In terms of its movement, it's a biaxial joint. It's a joint that can permit only two range of movement: flexion and extension, and adduction and abduction. And then finally, in terms of its structure, it's a synovial joint. So it will contain components or features that we see in a typical synovial joint. We mentioned some of the articular surfaces of the wrist joint already. Mention it again, the articular surface of the wrist joint includes the distal end of the radius, as we saw, the articular discs of the ulna, also called the ulnar disc. So the ulna doesn't take part, unlike the ulnar joint and the elbow joint. It's an articular disc that is involved in taking part in the wrist joint. And then finally, the proximal roll of the carpal joint. Note, it's not all the proximal roll of the carpal joint that forms the wrist joint. The only proximal rolls that form the wrist joint includes the scaphoid bone, the lunate, and the triquetrum. The pisiform is not involved in forming the wrist joint. This is an image showing us the wrist joint or the radiocarpal joint. You can see the different articular surfaces of the joint. We have the radius in yellow, the carpal bones in green. We'll mention them when we get to the articular surface aspect in the slide, and then the articular disc of just beneath the ulnar bone. Remember that the ulnar bone is not involved in forming the wrist joint. Let's talk about the different components of the wrist joint. A synovial joint is going to contain a joint capsule and ligament. Joint capsule of the wrist joint would have a fibrous portion and a synovial membrane lining it internally. For the ligament of the wrist joints, they include the ulnar carpal collateral ligaments, the radial carpal collateral ligaments, the palmar radiocarpal ligaments, the dorsal radiocarpal ligaments, and the interosseous ligaments. And each of these ligaments have their different functions. For example, the radial collateral ligament is involved in limiting ulnar deviation. It will limit medial deviation. The ulnar collateral ligament is involved in limiting radial deviation or lateral deviation, so it doesn't allow the wrist joint to deviate laterally in excess. The palmar or volar radiocarpal ligament is the most important ligament that tends to control motion and wrist stability, and it's a ligament that tends to attach to the anterior surface of the distal radius and insert obliquely on the on the carpal bones. And the dorsal radiocarpal ligament being the second one, it's also a ligament that tends to strengthen the dorsal part of the wrist joint. This ligament tends to limit wrist flexion. So dorsal radiocarpal ligament limits wrist flexion, whereas the palmar radiocarpal ligament tends to limit wrist extension. And then we have the interosseous ligament, that is a very minor ligament found within the wrist joint that tends to stabilize it. This is a picture showing us each of the ligaments. We have the ulnar collateral ligament at the side. Remember, it tends to limit radial deviation. We have the radial collateral ligament as well on the lateral side that limits ulnar deviation. And we can see the palmar radiocarpal ligament on the anterior surface, but we can't see the dorsal radiocarpal ligament because it's found posteriorly. The vascular supply and drainage of the wrist joint are by two different vessels. They include the dorsal carpal vessels and the palmar carpal vessels. And each of these vessels tend to either drain or supply venous or arterial blood to the wrist joint. The nerve supply to the wrist joint follows Hilton's law. This states that joints are supplied by the articular branches of nerves supplying the muscles that act on those joints. In the case of the wrist joints, the nerves supplying those joints, the joint includes the anterior interosseous nerve, posterior interosseous nerve, and deep and dorsal branches of the ulnar nerve. What are the movements that are found at the wrist joint, and what are the muscles involved in performing those movements? For flexion of the wrist joint, we have three major muscles: flexor carpi ulnaris, flexor carpi radialis, and palmaris longus. It helps to remember that each of those flexors have flexors in their name, hence the reason why they're involved in flexion. The only exception being palmaris longus. Extension of the wrist joint is done by all three major muscles as well. They include extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. So these muscles also contain extensor in their name. For adduction or radial deviation, the muscles are involved include usually muscles that contain radialis in their name. So we have the flexor carpi radialis, extensor carpi radialis, and extensor carpi radialis brevis. So extensor carpi radialis longus and brevis are both involved in radial deviation. Remember that radial deviation or abduction, muscles involved in doing that always contain radialis in their name. And then finally, adduction, ADD, or ulnar deviation is done by muscles that contain ulnaris in their name. So we have the flexor carpi ulnaris and the extensor carpi ulnaris muscles. This is an image that shows flexion and extension of the elbow joint and the wrist joint. Our major focus should be on the wrist joint. You can see flexion on the wrist joint involves moving the hands towards the forearm, and it's done by those muscles that contain flexors in your name, as I said. Extension of the at the wrist joint involves the movement of the wrist joint away from the forearm, or movement of the hand away from the forearm. It's like you giving a high five. That way, you're stretching out and straightening your palms, facing it forward. So these are the major muscles that we see at the wrist joint alongside adduction and abduction. Let's talk about clinical significance to the joint of the upper limb. We'll start with dislocations. And dislocations refer to the displacement of the joint or the bones that tend to form a joint. We start with some common form of dislocations that we see in the upper limb. Let's have a shoulder dislocation. So in shoulder dislocation, the head of the humerus is displaced from the glenoid cavity, and as a result, that joint is dislocated, quote unquote. Shoulder dislocation tends to occur more anteriorly because or anterior inferiorly because the weakest point of the joint tends to be found anteriorly and inferiorly. So the shoulder tends to be dislocated usually anteriorly and inferiorly. Then we have the elbow dislocation. Elbow dislocation is also a very common form of dislocation that we see. In terms of elbow dislocation, the radius and ulna will be dislocated from the humerus, the distal part of the humerus. And in terms of elbow dislocation, we tend to see that occurring posteriorly. So the elbow tends to be dislocated posteriorly rather than anteriorly. Other clinical significance to pay attention to will be what we call bursitis. Bursitis is inflammation of the bursas found within a joint. Remember that bursas are found in some particular joints of the upper limb, like the elbow joint and the shoulder joint. So inflammation of these bursas is what we call bursitis, and it can be very painful around that joint region. Another clinical significance is what we call tendinosis or tendinitis. This is when there's an inflammation of the tendons or muscles acting on the joint. One of the commonest form of tendinosis that we should know about around the elbow joint is golfer's elbow and tennis elbow. Golfer's elbow is when there's an inflammation of different tendons found at the medial epicondyle close to the elbow joint, and this tends to occur in people that play a lot of golf, hence the name golfer's elbow. And then we have the tennis elbow. Tennis elbow is inflammation of tendons around the lateral epicondyle close to the elbow joint, and this tends to occur in individuals that play a lot of tennis. Then we have some other aspects of clinical significance that are not necessarily pathologies, like carrying angle. Carrying angle refers to the angle that tends to occur when there's a flexion or extension around the elbow joint, and it helps us in the carrying of different things like bags, buckets. As a result, that ability to flex and extend on the hinge-like elbow joint due to the carrying angle is what makes it very unique. Other things to note will be dislocation of the head of the humerus and the wrist fracture. Dislocation of the head of the humerus, for example, tends to present with a number of difficulties or anomalies. Some of them would be you could have a joint dislocation and fracture of the ulna alongside the radius, usually either even in the proximal part alongside the distal part. So this is an image of the shoulder dislocation. Remember, shoulder dislocation can occur anteriorly or posteriorly, but we tend to see more of anterior dislocation than posterior dislocation because the weakest point of the shoulder joint tends to be anteriorly and inferiorly. This is an image of the shoulder dislocation again seen on X-ray. This is a possible question they can ask you in your practicals. They can bring a radiographic image of shoulder dislocation and ask you to identify where the problem lies. This is an elbow dislocation. Remember that elbow dislocation can occur anteriorly or posteriorly, but what we commonly tend to see is a posterior dislocation of the elbow. In this case, this form of dislocation occurs when there is a displacement of the ulna and radius posteriorly compared to the head of the distal part of the humerus. This is an image of a posterior elbow dislocation. As you can see, the head of the radius and the trochlear notch of the humerus have been dislocated posteriorly, and they are displaced posteriorly compared to the distal portion of the humerus, as you can see. So this is the posterior dislocation of the elbow. Right, and this is an image of a tendinosis. Tendinosis occurs when there is an inflammation of the tendon around a joint. In the case of the elbow, you can have a tendinosis of lateral at the lateral epicondyle or at the medial epicondyle, and this can be called a Colfax elbow or a tennis elbow. In the case of this individual, it's not really shown, but it's likely going to be a Colfax elbow, which is a an inflammation of the tendons at the medial epicondyle. This is what we refer to as the carrying angle. Carrying angle is seen as the angle between the plane or line drawn from the humerus down to the forearm. So the angle between the humerus, the axis drawn on the humerus, and the axis drawn on the forearm is what we call the carrying angle. And this angle is involved in a lot of a lot of activities when we're flexing or extending the elbow. And that concludes our model on the joint of the upper limb.